High-frequency ventilation is a form of mechanical ventilation that utilizes very high respiratory rates but very small tidal volumes, often smaller than the volume of anatomical dead space. The FDA considers any ventilation mode that provides more than 150 breaths per minute to be high-frequency. There are mainly 4 types of high-frequency ventilators. Those being high-frequency oscillatory ventilation, high-frequency positive pressure ventilation, high-frequency jet ventilation, and high-frequency percussive ventilation. While each mode is providing high respiratory rates, each mode exploits different details to accomplish this goal. Each of the differences provide unique benefits and creates other complications. This lecture will focus on high-frequency jet ventilation. The high-frequency jet ventilator is a microprocessor-controlled, pressure-limited time-cycled mode of ventilation that utilizes pulses of gas through an injector to achieve ventilation. The Bunnell LifePulse is the only device on the market for use in neonatal patients. The 2 models of the LifePulse are the older 203 model and the more recent 204 model. The newer model provides the advantages of a built-in battery, improved electronics, enhanced user interface, prioritized alarm hierarchy, and a quieter water pump. When the jet ventilator was initially available for use, utilization was limited because the patient had to be extubated and reintubated with a specialized endotracheal tube that allowed for the delivery of jet pulses. Also, the user would need to frequently monitor ventilator pressures and adjust servo pressures accordingly. These barriers were overcome with the creation of the LifePort, which would connect to the endotracheal tube, which provided a port for the delivery of jet pulses and monitoring of tracheal pressure and servo adjustments. Historically, support and utilization of the jet ventilator was challenging. Most of the controversy revolved around the findings of a study Weiswall et al. And another by Kessler et al. Weiswall examined the effects of jet ventilation for the treatment of respiratory distress syndrome in preterm infants receiving surfactant compared to standard ventilation and found the jet ventilation group had more adverse outcomes, including periventricular leukomalacia and death. Kessler examined the effects of jet ventilation for the treatment of respiratory distress syndrome in preterm infants who received surfactant and found no increase in morbidities and significant reduction in the development of bronchopulmonary dysplasia. Other studies by Engel et al. And Davis et al. Found improvements similar to Kessler along with no increases in mortality. When taken at face value or only by reading the abstract, some providers developed the belief that the jet ventilator had no benefits or increased the risk for harm. However, the devil was in the details, or the methods section. The conflicting results may be attributed to differences in ventilator management. Kessler used the jet to optimize mean airway pressure while Weiswall used the jet to minimize mean airway pressure. For example, Kessler started patients on PEEP levels of 4 to 5 compared to 6 to 8 in the Weiswall study. The approach to the management of ventilation also differed. When the patient's carbon dioxide levels decreased, the tidal volume would need to be weaned. The Weiswall group would lower the peak inspiratory pressure without changing the PEEP, resulting in a lower pressure change, thus a lower tidal volume and a reduction in mean airway pressure. The Kessler group would lower the peak inspiratory pressure while increasing the level of PEEP to reduce the pressure change while maintaining the same mean airway pressure. While neither group was wrong, this does highlight the importance of management strategies and the value of experience with mechanical ventilation. Further research with the jet ventilator remains limited. In 2000, a Cochrane review compared the jet ventilator and conventional, but the only trials were the ones by Kessler, Weiswall, and Carlo, which found reductions in chronic lung disease and no significant differences in mortality or intraventricular hemorrhage. When the Cochrane review was performed again in 2006 and 2015, no new research was available. In 2017, Cochrane attempted to compare the jet ventilator to high-frequency oscillatory ventilator, but no studies met the inclusion criteria. As of 2024, a literature search for high-frequency ventilation remains limited to its application during certain surgical procedures like bronchoscopy and ENT procedures, although this utilizes a different device, approach, and only utilized during the procedure. Other results provide the results of single-center studies. This only highlights the challenges for researching mechanical ventilation. With mechanical ventilation, there are numerous variables and outcomes that could be measured along with inconsistencies in how the ventilator is managed. When approaching mechanical ventilation strategies, it is important to understand the approach must be individualized to the patient based on their underlying disease and severity. The approach must be one that multiple providers have experience and are confident in its use. Further, if providers are new to the approach, there should be appropriate training and decision-making tool. With mechanical ventilation, experience and skill matter. However, providers cannot ignore new strategies and approaches. If providers find gaps in the literature, gather a team and perform research to fill that gap. Doing the same old thing or taking the approach of if it's not broke don't fix it or the institution's way violates continuous quality improvement and professional development and leads to non-relevance and obsolescence. Also, these phrases are used as shield to resist change. Instead, fix it before it breaks and be forward-thinking.